So I'm going to make sure to go around Michael.
I agree with what everyone said. Just separating out.
Just two groups.
But I just want to, I guess, in addition to agreeing with everyone, including what Dan said on good medicine, is to remind ourselves that we're also fighting against the epidemiology of disease here, which is going down. There's been a tremendous decrease in CVD over 20 to 50 years.
I beg the difference, right there.
There's no question about that. That's clear.
Age-adjusted,
Yeah.
yes. But that's what epidemiologists love to do.
But I'm just saying,
Society-wise, we didn't go down.
but to find your 50% risk patient when, you know, second smoke's going down, and trans fats are going down, and guys in general being better on statins and whatever stuff, it's going to be exceedingly hard. The fighting against the epidemiology was to try to find this person, because you're talking about prevalence,
Yeah.
not talking about incidence. Incidence is going down. To find a person with really that 50% risk, it's going to be, it's hard.
I said adjusted incidence, age-adjusted incidence is going down. Incidence is not going down.
Incidence is going down.
Prevalence is not going down.
Right.
Because some population is getting older.
That's right. You're talking about incidence, you're talking about a rate of disease that's that high over 1 year. I'm just saying, it's going to be hard to find the level of risk that you're talking about, I think. But
Oh, you're saying it's good? Well,
I mean, the epidemiology is saying that the incidence is going down.
It's going down, but it's still-
We're trying to find someone with such a high 1 year incidence that would justify some other, despite how good medicine's getting, despite we are learning a lot more about.
right, but we had 600,000. But we had 600,000 STEMI last year.
Right, the denominator's getting bigger too.
So, don't we want to find them before a STEMI?
No question.
If
I'm echoing, I guess, a lot of what I've heard, but the challenge of it. But I think the epidemiology points to the fact that the challenge is very, very hard.
with the epidemiology approach, primary prevention and diet and so on, that is slow to get a good shape one to do eradicate heart attack, we'll have to go another 100 years to get to eradication.
Right, I'm just saying that in terms of finding, and I guess we tried from 50 to 25 and maybe extended it a couple of years, but to find a person that's really that high of risk in the modern era with environmental exposure to medicines, I just think it's extremely challenging.
Okay, I'm
It's not an easy task.
No, it's not. We don't have the tool right now. We don't have the tool. My point is, all of those people are going to fall off the cliff in the next 12 months. And be STEMI or MI, if we detect them a few months before, that's what would be the high risk. Like a very high risk.
Too high a bar with the model that we're talking about right now, where we're thinking about intervening with bypass surgery. And we're thinking about a 50% 1 year risk. That's an unreasonably high bar. We're not going to get there anytime soon. It's going to be another 12 years or maybe 24 years. It's going to be a long time.
You mean we're not going to be able to develop the tool that predict
Not
such a short?
realistically, not over the next 5 years. But instead, we do have intermediate goals that are realistic. And with those intermediate goals, lower level of risk, we could up titrate or down titrate medications, a more complex group of medications than simply aspirin and statins. So we still have an opportunity to impact care, but we should change the paradigm a little bit where we're not taking such a high bar that requires transplant.
Well, I mean, I was just trying to draw an analogy with cancer. What do you do when you find a tumor?
You're still working with intermediate risks. It's not a stage 4 cancer. I mean, we don't have to limit ourselves to the highest risk, but we can deal with intermediate risk groups where our expanded group of medications require some more thoughtful development of how we're going to give those.
Maybe more population, closer to the
You
middle.
know,
Yeah.
I tell you that what Ahmed is saying, it is extremely important that we must realize this. I distinctly remember when I was back in Mass General, one of the transplant patients, when I was doing my transplant fellowship, the patient was there for 4 months. At that time, we did not send them home. We used to keep them on dobutamine and dopamine in-house. and we would not send them home. LVAD had not come and all those things. I'm talking of the previous age. But this guy, 4 months, he was green actually. His bilirubin was 21 and with heart failure, and was being nursed there, got a heart, 7th day. First question is, when can I smoke? You know, I mean, MI, totally ballooned up heart, and now the first thing that he's asking is, when can I smoke? You know, it is a problem. You have the patient with the IV drug abuser, infective endocarditis, the patient is saved, and the moment he gets back home, the first thing he starts doing is so question is, it is essentially what Dr. Fuster says. He says the only time you can impress a person is when he's between 3 to 5 years of age. Why? You have got multiple centers in brain. They don't have the connection still. You have centers. You don't have the connection fibers as yet, which are maturing.
Yeah.
Once the connection fibers start coming in, the person starts thinking. He starts using his logic, whether I should be eating it or a little bit I can eat, and then, so you have to start impressing on these guys right from day one that, you know what, you don't have to eat this, you don't have to eat that. And that is why all the data that he produces from Colombia, it clearly shows that these 3 to 5 years old kid, you teach them for 6 months, their knowledge, attitude, practices, they all improve. You stop the teaching at 6 months, it continues to improve. In teachers, it improves in parallel because they are also listening to the lectures. But then at 6 months when you stop, they become flat. In parents also, they come home and they tell their parents, it is improving, and 6 months later it starts to fall. You know, so we are incorrigible. Yeah. So question is, that if we have to go, and his mantra today is education, 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 right? And education earlier on. Again, now the question is, what do we do to scare the people? Now that you have to see whether we can make same scare as cancer. Where I don't know why people are scared more of cancer than they are of.
Well, no, there is a reason. They know they're going to die. They know the moment that you tell them you got a tumor, at stage 2 or 3, they know it is death. Coronary disease is not. I mean, with epidemiology, we know, 300 out of 100,000. That's the, 600 out of 100,000. Even that does not. But when you look at, compared to cancer, when you tell them you're going to die, chances of 1 out of 2, 1 out of 3, you cause a lot of things. Their adherence to treatment, they adhere to chemo, which is the worst therapy they get. So I was trying to draw things that we've talked in the other, so let's refer to Amit's category, the first and the second. In the first category, we've done everything in the past 30 years. Unless we have a more intensive acting drug like PCSK and cheap and so on, I can't think of anything else. But in the second category, if we are able to identify the vulnerable patient, and throughout this analogy like cancer, that the tumor that knows, that person knows it's going to die or have a major, Okay, let me do a quick analogy. PSA. There was a slide when I presented our proposal to Google. If you look at PSA in the United States, the spread, or the incidence and prevalence of metastatic prostate cancer was going up like this. In 1960, 70, when PSA was detected, there is a sharp decline in metastatic prostate cancer. I would like to draw an analogy metastatic prostate cancer to STEMI and MI. If we are able to find a PSA and we are able to admit it population level, I predict that we're able to get a significant number of the MI and the STEMI down in that population. This is a hypothesis. We don't have the tool yet, but if IBM Watson, or Google, or Facebook, if they want to come in, and if we are able, we already put together the cohorts, you know, that we have now 23 cohorts from Framingham, Mesa, European, all that. And we get people who died or had an event a few days to a few months, maximum 12 months after their blood draw and their exam, and feed every data that we can get from these to the machine learning. These are the vulnerable patients. They just had blood draw, coronary calcium, 4 other clinical and
More, do you have the cohort? Do you have 23,000 patients or whatever you're saying?
So we put these expected numbers based on the data that we got, like from Raymond Herbal, from
So
HNR.
that's I think what you should be working on now.
That's
You
what
should-
we're working on.
You should curate, you should be curated also. You know, the data needs to be curated. You can't
So we're
dump
meeting,
it into there.
yes, yeah,
So that's what, I mean, that's what you should be working
yeah,
on. now,
so
so.
we're meeting with IBM Watson next month.
No, but IBM Watson is the tool, but you have the data. They don't have the data.
No, funding.
Funding.
To go to all of these blood samples.
Okay.
David and the Stanford will be collecting
I forgot about that.
money.
I forgot about that.
The coordinating centers, the collecting samples.
On this note, I think we should end the meeting.
That's
Money.
exactly what we're